one more plane could only catch your name. We took a crazy tour, I'll find a perfect cure. For every stressful day there came a gray. Back to reality, I need vitality, 'cause I'm really fine but kinda cold. And I need the sun, I need a day without the rain to feel alive again. Alive again, I need the sun, I need a day without the rain to feel alive again. Alive again. Your youth and energy mark my memory, so I call your charms gift just any harm. Freedom by the sea, freedom makes it real. There's nothing that's more special than this place. Back to reality, I need vitality, 'cause I'm really fine but kinda cold. And I need the sun, I need a day without the rain to feel alive again. Alive again, I need the sun, I need a day without the rain to feel alive again. Alive again, loving you by chance, I never knew you'd be my only final destination now. There's nothing I can do when I come right back to you, so save me your place and carry me away. Back to reality, I need vitality, and I'm kinda fine but really cold. And I need the sun, I need a day without the rain to feel alive again. Alive again, I need the sun, I need a day without the rain to feel alive again. Alive again, I need the sun, I need a day without the rain to feel alive again. Alive again, I need the sun, I need a day without the rain to feel alive again. Alive again, oh yeah.
Hello and welcome to day 2 of the 20th International Conference on Integrated Care. Today we will be focusing on digital health and other tools for supporting the implementation of integrated care. Shortly, I will hand over to my colleague who is known to many of you, Leo Lewis, who is Director of Research and Development here at the International Foundation for Integrated Care. And she is coming to us from her home in Aberystwyth in Wales. And we will also be handing over to Professor Zlata, who is a specialist in family medicine at the University of Zagreb, who is one of our conference partners. And she is coming to us this morning from our co-hosts at the Health Centre Zagreb. Before I do that, I would like to remind you that you can catch up again with the opening ceremony and our first plenary from last week. And all the breakout sessions were recorded from day 1 by going back to the 9th of September on your portal. All of today's sessions will be recorded and available to access before the end of the week. Please take the time to explore all the functionalities in the portal. We know it's not as good as meeting people face to face, but hopefully you will have the chance to connect with some old friends and meet some new ones today. I'll hand you over now to Orla Snooko-Carroll, who is Digital Marketing Manager here at the Foundation. She'll tell you a little bit more about the portal and how you can make the best use of it. Orla.
Thank you, Fiona. So yeah, we're really excited by our virtual platform that we have, the Events on Air portal. If you haven't already, check out our explainer video, which is located on the top right-hand corner of your screen. And if you click on your photo or your initials, it'll bring you there. Also, if you need any technical help throughout the conference, just click on the live support button. That'll bring you to our team who'll be happy to help you. If you are having a break or are on any lunch breaks, visit our exhibition stand where you'll see all of our exhibitors. Also visit our poster galleries where you can download and view all of our posters. So without further ado, I'll hand you back over to Fiona and she'll introduce Plenary 2.
Thanks, Orla. Okay, so now we'll hand you over to Wales and Croatia, to our co-chairs, Leo and Zlata, who will introduce today's plenary session, which is looking at the use of artificial intelligence and digital tools in people-centred integrated care.
Thank you very much, Fiona. It gives me great pleasure to welcome you from wherever you are in the world to join me as one of the co-chairs of this plenary session, kicking off the second day of our virtual ICIC 20. During this session, you will get some insights into how digital solutions are being deployed as a key enabler for delivering integrated care. Over the last 6 months, we have seen a huge rise in the use of digital solutions, particularly those supporting teleconsultations to ensure service continuity. We now need to ensure that we understand how they can be sustained and augment aspects of people's care and support so that they provide an enhanced experience and contribute towards improvements in outcomes and avoid impacting negatively on health inequalities. Unfortunately, the first speaker has been taken ill this morning and is unable to participate in this plenary session. His presentation will be recorded and available in the platform later this week. However, I'm delighted that Ingo Meyer has stepped in at the very last minute this morning. More about Ingo shortly, and we will be taking questions after the 3 presentations. So please don't forget to put your questions within the Q&A box so that we can ensure that we pick those up and have a lively Q&A session after the 3 presentations. Whilst our speakers this morning come from healthcare, policy, research and industry sectors, we must not forget the importance of social care and support services, together with our service users and their families. And I would like to hand over to Zlata, who is going to tell us about a couple of examples of how digital solutions in Croatia have included these perspectives, and then I will come back to me to introduce Ingo Meyer. Thank you, Zlata.
Thank you very much, Leo, for introducing me, and I also feel very privileged to be here today as the co-chair for this very interesting session. So both from the perspective of mine as a teacher in family medicine and also as a practicing physician, I feel that the solutions that the digital world is offering in terms of integrating care are really challenging and actually the future. It's not only the integration of primary care from which I'm coming, but also from the upper levels of care, and of course the social context needs to be taken into consideration. So the social care services are really the next step that we are looking forward to integrate. Croatia has done a lot already in implementation of digital solutions in the healthcare sector. On the primary care level, we are also very much connected with the community nurses that are actually forming like a bridge between the healthcare but also the social care needs of our patients and our citizens living in the community. So the next logical step would then be to broaden this integration and also to connect the social care services into this network so we can share information in real time, which is quite often crucial in solving the issues that our patients are having, especially when it comes to the ones that have highest healthcare needs. And as we know, and as the Julian Tudor Hart has stated even 50 years ago, that there is an inverse care law and that the ones with the highest care needs actually tend to use healthcare services the least. So in a way, we need to make all that we can to ensure that we overcome these inequalities in using of healthcare services. And for sure, digital solutions are one of the steps that can help us in that way.
Thank you very much, Zlata. So now we'll move into our presentations, and it gives me real pleasure to introduce Ingo. And once again, thanks for stepping in last minute, Ingo. Ingo is a senior researcher and head of the PMV research group in the University of Cologne. He holds an MA in sociology from Bonn University and started work as a data analyst and statistician, building up now in having 15 years working in the health and social care domains on research, consultancy and service provision. He analyses data from primary and secondary care, including claims and routine data, and this being one of his core competencies, along with extensive skills in data management, conceptualization, and implementation of data infrastructures. He also works on the implementation and evaluation of integrated care service concepts. So over to you, Ingo. Thanks.
Thanks to you, Leo. Thanks for having me, and good morning to everyone out there. Greetings from Cologne, which is where I'm based, as Leo said. So you can see a bit of the city of Cologne and the cathedral in the back, although that's unfortunately not the view from my office. So what I wanted to do in starting off this session is to give you a kind of an overview or an intro into the topic, because this is something that has been on the table for quite some time, and it's certainly being discussed quite a lot in the German health research and healthcare fields. And so I thought I'd just gather some information and present it to you. And what my feeling was when reading into the topic is we are in between a hype and a reality. And I put it in the title quite bluntly. Are we looking at our redemption? Are we looking at our damnation when we are talking about artificial intelligence in healthcare research and in practice? I don't know how you feel about it, but my impression certainly is that there is a hype around artificial intelligence. And for some reason, the topic has popped up big time in the last couple of years. And if you read not just the scientific literature, but also more into the, I don't know, what the news report about it, what people say about it, you could think that we're caught in between two paradigms. And I'm putting up two images here. So what is artificial intelligence? There's one group of people, you could say, that see artificial intelligence as kind of our salvation. So everything will be good once we are really using artificial intelligence throughout, but particularly in healthcare and in medicine. And I don't know whether you realize that picture that's from the 2001 Space Odyssey. And that's an image of the Star Child, I think it's called in the English version, in the original. So a kind of godlike being that has been created from a computer conscious. So that might be the hope behind artificial intelligence, that we are kind of uplifted beyond anything that we've achieved so far as humanity, and can create a better world. As I said, we're talking about a hype here. The other view is that guy here, which you also recognize, which is the T-800 Terminator robot. And so that's the fear behind all of that artificial intelligence leads us into a kind of dark age of machine rule, really. And the robot, for example, I think that is a nice expression also of some confusion. What are we talking about when we say artificial intelligence? Are we talking about statistics, a particular way of doing statistics, or are we really talking about creating artificial conscience? So there's a lot of muddied waters, I would say. On the positive side, and maybe breaking it down from the star chart a bit, and Leo and Zlata, they've talked about this already. What are we talking about in terms of hopes or expectations in the positive sense around artificial intelligence? Well, you could, for example, link it to the quadruple aim. We are hoping for lower cost and better quality. We're looking for an increase in equality. Like I said, finding the people that are in need of health and social care and all other types of support. We're also hoping for better access. On the downside, we're looking maybe at the rule of the machines, but we're certainly looking at some very real concerns when it comes to pulling all the data together, analyzing them, linking them. Where in Germany, we use a lot the term of a data kraken. So an octopus, that's a term that we apply to companies like Google or Facebook that have their arms in all the data sources and pull them together, and usually, mostly or only to increase shareholder value. There's also a risk of discrimination increasing due to increased data transparency. You will know more about people the more you link data together and the deeper you analyze them. And that means you can actually discriminate against people. You can exclude too expensive groups from healthcare, for example. And there is a number of further ethical issues around here that need to be taken into account, and that, to my mind, make it clear that the fears around artificial intelligence are not unfounded. Certainly, the topic is big. I'm looking at the German situation here. We have what we call the Wissenschaftsjahr, the science year. That's a kind of national initiative. And in 2019, the topic of that national initiative was artificial intelligence. For the first time ever, we have a national AI strategy of the German government. We find and have been finding for some time artificial intelligence as a topic in grant schemes that includes, for example, the European Horizon 2020. But also in Germany, again, we have this innovation fund that funds innovation in healthcare and health services research. And here too, we are seeing an increase in topics that ask us to address artificial intelligence. But what is the reality? Let's look beyond the star chart and the Terminator. Again, that's a German thing, #Neuland, #new country. That's something that we use when old politicians start using technology and are not very good at using it. And then the joke around it is #Neuland. That's something new to them. But is artificial intelligence really something new? In a sense, it isn't. And you are probably aware that the first applications in medicine are there since the 1960s, and I'm talking about the statistical part of artificial intelligence. What I did in preparation for this talk is I looked at one publication by Becker, Artificial Intelligence in Medicine. What is it doing for us today? And what she did is she did a PubMed research of the terms artificial intelligence and medicine, or machine learning and medicine, in the time span from 2015 to 2019. Now, what she found in terms of a word cloud, unfortunately, I did not manage to translate this for the presentation today. So maybe if you focus on the right-hand side, where I basically summed it up in English, what did she find in her literature research for these terms? She found that artificial intelligence is being written about in different areas of application. And the main areas of application are the prediction of risks of disease and the prediction of treatment success, the management of complications around conditions and treatments, the support of ongoing treatments, and the research into pathologies and interventions. And if you look at the word cloud and only learn one German word today, it's Erforschung. That's in the middle here, that's research. So there's a lot of research going on using artificial intelligence in medicine. In terms of the data being used, what Becker found is that a lot of data comes from hospital information systems, from electronic patient files and their different variants, from genome data, from image data, and from audio data. What struck me here, and I think that's particularly important in the context of the Integrated Care Conference, artificial intelligence in medicine is being used for a lot of diagnostic tasks in the widest sense, but not a lot of support of ongoing treatments. So when I think about care pathways, integrated care pathways, and things like that, artificial intelligence seems not to have made its way into that field yet to any large extent. Let me give you a more detailed view on a number of more specific topics. I don't know whether you are aware, there was a report created by the organization Algorithm Watch in cooperation with the German Bertelsmann Stiftung and supported by the Open Society Foundations. And they looked also at the situation in relation to what they called automated decision-making in the EU. And if you first look on the left hand of the new slide, what they are proposing is, or they are asking whether artificial intelligence is really a good term to be used. And think back to what I said about, are we talking about statistics or killer robots? So maybe they say, let's talk about automated decision making, which aligns better with analytical statistics, machine learning. So it gives us a closer focus of what we're talking about today and points us to a very important element of that, which they highlight, and that's the algorithms. And here, and those of you who know the Algorithm Watch, that is their very topic. Who makes the algorithms? Who tests the algorithms? Who supervises the algorithms? So again, we're back to the ethical issues to some extent in the beginning. If we leave decision making to automated systems, how transparent, how quality approved is that decision making? We had it before, the question, are we talking about something old or are we talking about something new? Are we talking about artificial intelligence replacing areas of healthcare, or are we talking about artificial intelligence supporting healthcare? Or are we maybe talking about something very old, which is the good old garbage in, garbage out? I've copied you on the right-hand side an interview with the mathematician Gerd Antes. He's a German biometricist. And I don't know whether you know him. He's quite famous or infamous, depending on where you stand in Germany, as the former head of the Network for Evidence-Based Medicine and also as a big face in the Cochrane movement. So he has a very hardcore view on evidence and the solidity of evidence. And he was given an interview in the Austrian magazine Der Standard, where he very much argued against any use of artificial intelligence. And I found that striking, and I dug a bit into his reasons why big data, I mean, he was talking about big data and the analytics are not good and should not be used. And his main reasons were that correlation should not be confused with causation. There is too much signal to noise in relation to noise, not enough signal in relation to noise in the data. The signal to noise ratio is bad in data. There are spurious correlations, and especially real world data are often of bad quality and are riddled by errors in the data. So basically I thought what he is saying, bad data and bad methods lead to bad results. And that's why I said garbage in, garbage out earlier. We are talking about some very old data topics, and I was really wondering after reading that article, in how far is that argument really an argument against big data or artificial intelligence for that matter. So to wrap it up, we've come a long way, as I said, since the 1960s, but we also have a long way to go because there's a lot of arguments still going on that seem not to be well thought through, to put it like that. What is here to stay? Artificial intelligence as a topic, to my mind, is here to stay, as are its potentials and its challenges. I think we will also not be able to evade that topic. We have to deal with it. But we will have to continue producing solid scientific results to do solid scientific work. And to my mind, that's what remains from Gerd Ante's statement. You just have to do good work, even if you're using big data, even if you're using artificial intelligence. That will not relieve you of that necessity. What needs to happen? Big data is defined, or one way of defining big data is using the big V's: high volume, high velocity, high variety, high veracity. If I look at the kind of data we are working with at the moment, and at the University of Cologne, I'm working in the analysis of claims data from health insurance. Those are big data sets, but they are not big like that. Comparing to what, I don't know, Amazon is using or other artificial intelligence applications are using, I don't think we have high volume data very often in healthcare yet. We rarely, if ever, have high velocity data. None of the work that we are currently doing is about real-time use cases. It's all looking back, historic to some extent. High variety, when I see how many people in the field of health services research shy away from real-world data, I also think we're not yet there with high variety. High veracity, yeah, I leave that up to you. So I think we're not there yet in terms of the data we are currently analyzing, and that's maybe also why we're not seeing the full promise of artificial intelligence realized yet across the board. I'm not saying that we're not seeing it in very good use cases, applications, and research going on, but across the board, and maybe with a view to healthcare provision rather than research. I'm not at all sure that our data infrastructure at the moment is up to the task, especially when I look at the high velocity requirement and the idea that healthcare, social care, and other data needs to be shared in real time across organizations and then pulled together for analysis. I don't think we even technically can do that at the moment, not in terms of what is technically possible in principle, but in terms of the actual technology we are using at the moment. And coming back to a lot of the criticism, I think we still need to separate the good from the bad and the ugly. We are still not sure for a sufficient number of use cases how and where automated decision making or artificial intelligence is better than classical statistics. I heard a couple of presentations last year at a German conference where they had done some analysis where they found that the machine learning methods did not yield any better results than standard logistic regressions. But I think, again, that's maybe an artifact of the data we're using at the moment. And once we come to data sets that are actually too big to address them with logistic regressions, we might be seeing more of what artificial intelligence can do. And we need to become clear about which data are fit for what purpose, because I think we're also lacking practical experience at the moment with a lot of data, and I'm particularly talking about real-world data here, so coming from health apps and so on. So that's it. Thank you very much for your attention here, and thanks for listening to me. I'm open for questions. I've put you up 3 more further readings if you want. That article or that report about the algorithms is available in English. The other 2 articles are as well. And you can also find my contact details if you want to get in touch with me directly. Thank you very much.
Thank you very much, Ingo. That was a very thoughtful and thought-provoking presentation given by you. So we hope to get some questions put in our Q&A box as we move into our second presentation of this morning. And it is my pleasure to welcome Ran, who has many strings to his bow. He serves as the founding director of the Clalet Research Institute, the WHO Collaborating Centre on the Non-Communicable Diseases Research, Prevention and Control. He also serves as Chief Innovation Officer and Head of the Innovation Division for Clalit, which is Israel's largest healthcare organisation. And within these roles, he's responsible for strategic planning of novel organisation-wide interventions for improving healthcare quality, reducing disparities, and increasing effectiveness. These include the introduction of innovative data-driven tools into practice, predictive modelling, real-life effectiveness studies, decision support tools, and proactive care. In addition to this, I'm just highlighting a few things here. He serves as chair of the Israeli Society for Quality in Healthcare and as an advisor to the Israeli Ministry of Health, and as a board member, until very recently, a board member of IFIC. That's how we know Ran so well. And he also is serves as Commissioner for the Lancet and the Financial Times Healthy Futures 2030 International Commission. You can read more about Ran within his bio. So I will now hand over and we will learn about artificial intelligence and how data and artificial intelligence are being used in Israel. Thank you, Ran.
Thank you so much, Leo, and thank you everyone for this opportunity to speak with you today. I will now share my screen, and I hope this will be, I hope you can now see the screen. Okay. If everything works well, yes, I think it is. So good afternoon, everyone. What we will try to do today is to take a sneak peek into what we call augmented people-centered integrated care, and how we are trying to put predictive care into practice at scale in Israel at Clalit, and some more general messages that can be learned from the path that we've been taking in the last decade and a half. So in order to kind of jumpstart this, I want us to think about what would happen if we all had the gift of being able to look into the future. To look at someone and know that something bad is going to happen to them, and that we could do something to take him out of harm's way. Now, that would be amazing, wouldn't it? Now, imagine what healthcare would look like if that was a possibility. Maybe instead of going to your physician when you have an ailment, when you feel bad, one morning she would call you and you begin talking. Hello, how are you? I'm good. I'm good. That's great, she will say. You know, it would be great if you can come to the clinic today, because our data suggests you might have a heart attack in 6 hours. So in order to completely prevent this, we just need you to hop over. We'll fix things, and then you'll go on with your day. Now, this slide sounds like some of the science fiction we heard in the previous presentation, but actually, something very similar to this. This concept of predictive medicine is already put into practice, and even at scale. I'll give you one example from the realm of chronic kidney disease. Some of you might know how debilitating and problematic this condition is to the patient, to their family, to the health system, in every way and shape possible. But in this disease of chronic kidney disease, you cannot come and begin treating the patient only when they show symptoms. Because by the time they show symptoms, a significant amount of damage has already been caused to their kidneys. And at that point, it's too late. If you want to make a difference in chronic kidney disease, you need to come earlier. When the damage is only on the pathological, scale, the patient looks well, they feel well, but you want to take care of them then. You cannot do this because everybody looks well and feel well. How would you know which are the patients you should address? And this is where data-driven population health comes to play. And this is where AI can play such a major role, because it allows us to look at all of these patients and say which one has minor changes in, for instance, their blood tests or other elements of their healthcare setting that tell us that they are on their path towards dialysis and towards end-stage renal disease. And this is not a theory, this is something that we're doing. We have been doing for over a decade. We've been identifying those patients early on and changing their care, and have seen a significant decline in the rate of transition to end-stage renal disease. And this kind of approach is really, if you'd like to think about it, a paradigm shift. From patient level, reactive therapeutics, which is what we're doing now on most of the cases, to population health, to predictive, proactive, and preventive care in an integrated way to the entire population, people-centered in the fact that it's trying to prevent illness and suffering. Now, if you want to do that, what you need to do to create such a predictive model, you need a lot of data. You need to go back and have an ongoing large cohort of patients that feel well and look well, but you know every aspect of their care, every aspect of their lab tests. And through that, you can identify those patients that have transitioned to end-stage renal disease, and you can create a model based on it, which is what we've done. And we've done this because we have in Clalit, which is the largest payer provider system in Israel that provides integrated care, primary, specialty, hospital care to over half of the Israeli population, and has been doing so. The Clalit has been here for over 110 years, but in terms of having this type of data, we had it for over 20 years now. And so we've been using this data to create these types of models, because we have the data fully integrated. Primary care, hospital care, lab data, outcome data, morbidity, every aspect, hospitalization, cost, it's all in one database, all interlinked. So we can create these types of models. And so truly, this is what is the dictionary definition of what big data is, not just big in all of the 4 V's that were mentioned before, but already interlinked and curated and ready to create practical models from this data. And the Clalit Research Institute is the group of epidemiologists, scientists, clinicians, data scientists, mathematicians, all working together to create these models. And you know, there's different ways of creating these models. Some of these are, you know, classic regressions where you can see how the mechanism work, but some of these are more of a black box. And if you let the black box try to predict a future ailment, then, you know, sometimes you get really strange things. For instance, we wanted to predict osteoporotic fractures in our population, and we put the data into one of these black box machines that we have. And one of the outcomes that we got was that there was a very strong association between this and eye disease. Now, when I went to med school and when I look at my medical books, I do not know of an association, causative association between eye disease and osteoporosis. So this could be a fluke. But when you think about it a little more, it actually makes a lot of sense that eye disease will be associated with osteoporotic fractures, because those who have eye conditions cannot see well. If you can't see, you fall. If you fall, you break. And so this very simple causative pathway that wasn't clear to us at the very beginning became clear thanks to one of these, deciphering and looking into one of these black boxes that we are using on a day-to-day basis. Now, it doesn't end only with these types of, lab data. You can also put into practice other types of, especially of image data. In this case, we've been using with one of the startup companies we work with, Zebra Medical Vision, we used CT scans in order to augment additional data into those models. And apparently, those CT-driven augmented models with a computer vision approach allowed us to increase our predictive capacity considerably above and beyond all of the state of the art. And I think this is really meaningful to think about where medicine is heading for. So, doing all these type of research is all nice and good, but the future that we are trying to strive for is what we call an integrated learning healthcare system. You might know of the concept of a learning healthcare system. We're talking here about fully integrated healthcare system. When you start with your needs assessment, which happens at the mothership in the organization, and then the Research Institute creates the data-driven tools that we've seen. And then it goes into at-scale implementation with all of its difficulties, working with the teams on the front lines, trying to figure out how they run their business and how this can be integrated into their daily business and daily conduct of care. And then we complement this with an evaluation to see how it actually worked. So one of the things that we did a lot of work on was the care for the multimorbid patients. These are the patients that required the most integrated approach in order to provide effective care to them. And what we've seen is that by using an integrated approach of what we call the CC map, and you can read more about it in some of Professor Efrat Shadmi's publications. Efrat is the primary investigator on this work of the CC map. So this integrated nurse and physician work that is driven by a predictive model that identifies the patient at the highest risk has allowed us in a large-scale clinical trial of over 2,000 patients by now to be able to show that you see a 43% reduction in admission days, a 55% reduction in readmissions, and an overall cost-saving process. So the cost of the extra nurses and the extra time is actually lower than what you gain by reducing the number of admission days. So this is beautiful to see how this comes into practice. And by now, there are these types of predictive proactive care models are being used on millions of patients at Clalit daily. And in order to predict and prevent a stroke and prevent diabetes and prevent colon cancer and prevent, for instance, we give our flu shots every winter based on these predictive models. And when basically when COVID-19 came in, we said, you know, this is a classic thing where we can use AI and predictive proactive care to save people's lives. And when this disease only became manifested on March, we developed a mortality risk prediction model based on a pretty complex collaboration of data from other countries that already had a high mass of infection. And we put it into practice, and we sent SMS messages and physician calls to each and every one of over 200,000 patients at Clalit to tell them, stay at home, do not leave right now, protect yourself because you are at high risk. And I think one of the reasons that we see that despite the spike in illness in Israel, and the disease is now very dissemination in Israel, probably more than any other country, our case fatality rate is very, very low. Maybe lower than many other countries, most other countries. And the reason partially for this is because we were able to protect our most at-risk group patients. So, you know, it seems like it's all good. And this is working very nicely. And AI is really transforming care for the better and allowing us to provide predictive, proactive care. But there's also a dark side of the moon that we always have to take into account. And one of the things I want to highlight today, as a group that is highly interested in integrated care and in people-centered care, we have to tell the difference between diagnosis and overdiagnosis, between doing and overdoing. And obviously, we know lessons learned also in the United States and Canada that when we do a lot of diagnostic and proactive assessment on patients, sometimes we detect more disease, but we do not help the patients more. In this case, this shows that the added diagnostics on thyroid disease have increased dramatically the thyroid cancer presumed incidence, but mortality hasn't changed a bit. So the additional detection of what we conceive to be a problem does not necessarily mean that we improve the population health. And we need to remember this. And we need to choose wisely, and there's a choosing wisely international movement that we're part of. And on this sense, we have to understand that when in this age, we're adding more and more sensors, watches and sensors that are wearables. And we think that we are improving care and we are doing predictive work and we are doing proactive work. We need not to overdo this. And this is what I call here sensoritis. When you have too many sensors working and they bring in false alarms that cause a whole set of wrongdoing and overdiagnosis, and we need to be careful. The second thing that was mentioned in the previous lecture also is the issue of bias and fairness. And we know by now that there's a lot of problems when you're using AI in order to do predictions, because in many cases it's as racist and as biased as the data sets or previous practice that it's based on, and sometimes even more. And so it was said, I think, best by Kathy O'Neill a few years ago. She said, algorithms are not impartial judges. They're opinions embedded in code. And I think that is very true. We need to not trust blindly some of these predictions or algorithms. We have to use our judgment. And what we've done in our research institute is to increase the fairness of our AI-driven models by a methodology that we've developed here with a lot of collaborations with academic institutes that allow us to adapt our models after the model is being implemented, and reduce the variability and the predictive power according to the size of the subpopulation at interest. And through this process, we've been able to increase fairness without compromising accuracy. And I think these types of data or model outcomes manipulation to increase fairness is something that will have to be embedded in every process that we're trying to do integrated people-centered care and using an AI on massive scales in medical practice. So, you know, we are all working in a very conservative industry, and that's for a good reason. As we said, sometimes there's a very big difference between wanting to do the right thing and being able to do the right thing. And things that work well in the lab do not necessarily work well on the masses and on the populations. So there's a lot of risks on moving forward, and I've, you know, highlighted some of them. But what we should always remember, there are risks to the status quo. We are providing very non-optimal care in every country, including our own. We're doing, there's so much underdiagnosis, there's so much overdiagnosis, and there's so much missed opportunities to provide the right care, and a lot of mistakes and errors that we can prevent and predict through some of these automatic mechanisms. And we should be bold at this time, because by now the risk to the status quo and what we know since to err is human, and crossing the quality chasm that were published 20 years ago, there's such a great way that we should do in order to increase care quality, integrated care, and fully equitable and accessible care. And many of these new techniques can help us get there and provide integrated people-centered care. And so, you know, they always ask, will doctors be replaced by an algorithm? My answer is definitely no. Doctors, not anytime soon, not in the next decades, will doctors be fully replaced by algorithms. But I can tell you this, health systems that will not adapt, that will not learn to use AI in a judicious way in order to promote the values that they care most about, will likely be replaced by those who do. Thank you so much.
Thank you very much, Ran, for sharing how big data and AI is being used in practice and the impact it's having in improving and targeting care and services, as well as outcomes for our service users. Just one, if you can go to the Q&A, somebody is asking for the name of the main author that you quoted in the presentation. So now I'd like to hand over to Zlata, who is going to introduce our final speaker, and then we will come back to me for the Q&A session. So it's quite lively, which is great. So continue with some more questions in relation to Ran's presentation. Many thanks.
Thank you very much, Leo. I'm very pleased to be able to announce Professor Ante Marušić, who is presented today coming from Croatia. He's a specialist radiologist and also researcher at Department for Radiology, working at University Hospital Center Zagreb and School of Medicine, University of Zagreb. Professor Marušić has extensive domestic but also international working experience as a radiologist working in the United Kingdom and also United States, specially trained in oncologic radiology in the Memorial Sloan Kettering Cancer Center at Mount Sinai Hospital, New York. He has published over 50 articles related to this scientific area, and that is what actually made him become the leading radiologist in the National Lung Cancer Screening Program in Croatia that is ready and about to start in Croatia very soon. So Professor Marušić is going to give us a presentation on the National Lung Cancer Screening Program in Croatia, from clinical trials to nationwide implementation.
Hello everyone, my name is Ante Marušić. I am a thoracic radiologist at the University Medical Center Zagreb. I'm going to tell you more about our National Lung Cancer Screening Program, which is about to start soon. So where did we start from? Basically, why did we decide to do this? Because there is really high incidence of lung cancer in Croatia, as well as in surrounding countries. It is because of high rate of smoking. Particularly, we have problem with smoking in younger population, in teenagers already. So we are looking into this, and we would like to address this thing as well, this problem, through this program, and try to tackle that problem and hopefully improve the situation. Then beside that, we have really high mortality rate, which is about, we have 5-year survival rate of about 6% only. In the EU, it's about 9%, and US, it's more than 10%, it's about 16%. Survival rate. So we see that there are problems in early diagnosis of the lung cancer when we can still treat it and make people healthy again and live normally. We know what kind of nature does lung cancer have. It's really a nasty cancer, and most of our patients die, as already said. Now we know basically that the screening is effective. We have seen certain trials, starting with NLST in 2011, then in USA, which showed a 20% reduction in lung cancer mortality and 6.7% reduction in overall mortality. This was done by comparing chest radiography against low-dose CT. However, in 2018, we finally got the results from a large Nelson trial done in Netherlands and Belgium, and which really showed spectacular results. There was 26% reduction in lung cancer mortality in men, and 39 to almost to more than 60% reduction in lung cancer mortality in women. So we decided, let's go, we can do it, and we will do it. And so we defined the target population, which is 50 to 75 years of age. It's 30 back years of smoking history. It's less than 15 years since cessation of smoking. And those criteria are basically quite similar to NLST. So do we know something about risk assessment, someone is going to ask. And we are going to say, yes, we do know, but we saw problems in implementation, and we also saw problems in our specific population, which includes some war veterans, which are more which show higher incidence of all malignancies altogether. So we are still looking into these risk assessments. We have to improve the model to suit our own population. We know that PLCO is much better than NLST criteria. It showed to be more sensitive to detect cancer in basically healthy people. So we are going to move that way in future. How are we going to do it? Of course, there is publicity, public campaigns. We have already started with it early this year. We had really good feedback, a lot of interest in our program from potential candidates in the program to GPs and other professionals. And all over, public interest was really clearly shown. We have special softwares that we have produced for this for the purpose of this program. This special application is added to already existing central national IT platform for Ministry of Health or the health system. What have we done further on? We are going to have structured, clear, easily understood reports from LDCT, from radiologists and from pulmonologists as well. There are going to be 16 primary sites, like primary locations, where we are going to do LDCT scans, low dose CT scans, and 6 secondary sites. Those are pulmonology centers where patients can be diagnosed and treated adequately. We know that you suppose how difficult this was to go through bureaucracy and through all obstacles one can find there. So when you think that you reached somewhere, no, you haven't. You have to go back a couple of steps and then go on again. But one has to be patient and persistent, and every obstacle can be passed on. What have we done? Dedicated IT solution. In that way, the whole environment of the screening program is virtual and paperless, which is important. That is the first part of the Croatian national system, which is completely paperless, and we are trying to implement such system to the whole public health system, and this is really good and future. So what have we done? We put GP in the middle of things, and GP, they do know the population they serve, and they can detect people who are eligible for the program. They know about them, they are close to them, they know how to approach each of those people. That's why GPs are basically they are base of the program. They are the milestone. They can detect our candidates for the program. They have to do motivational talk to them, which I'm sure they know how to do. Once they do the enrollment of a person into the program, they are going to choose the time and the site for LDCT. They can see all available slots throughout the country on all 16 sites, and they can decide together with their patient how to, when and where to go. From that point of view, that is basically one thing that can ensure that those people are really going to show up on CT. I think they feel a kind of obligation to show up. That's when the person comes to radiology. Paperless, as we already said. A candidate shows up for the slot that was chosen before, and there they can sign the informed consent. They are going to get all other materials there, and they can ask whatever they like. We have already educated radiologists who are going to participate in the program. And radiologists are going to do a structured report with a clear message to GP, instruction what to do further with the person. Is the person going to go for a regular annual or later on biannual follow-up, or they are going to go for some other earlier follow-up, or they should be referred to pulmonologist clinic, which is going to be a part of a screening, so that the pulmonologist can go through the papers and check the patient history, and then decide if this is really something new or it already existed before, and then return the patient, the person into the whole process. Otherwise, if they decide this is something new and this has to be worked up further, then they are going to give structured report, and that way with clear instruction to GP to refer the patient for workup. After 6 months, the pulmonologist has to go back and fill in the second pulmonologist report, which is going to include the diagnosis, the staging of the tumor, and treatment, of course. If we find some kind of incidental findings, then the GP is going to refer the patient accordingly. So what the radiologist has to do is low-dose CT, low-dose computed tomography, which is 1 millisievert or less, which is then ultra-low-dose computed tomography, which we have one facility for. And then we face the problem, which kind of assessment system or screening protocol are we going to use? There are many of them out there. And what we have found is the comparison of 3 baseline screening protocols. It's ILCAP, it's Langrats, and European CIS protocol. And we found the ILCAP the most appropriate one for Croatia, and together with our support with our mentors from Mount Sinai Hospital in New York, Claudia Henschke and David Yankelis, who are really veterans in this job. We built up a new modified ILCAP system for Croatia, which defined the lung nodule as indeterminate or part positive if it is in between 150 and 2000 millimeter cube. Or in diameters, it's an average diameter of 6.5 to 15.5 millimeter, and positive findings are going to include nodules which are going to be larger than 2000 millimeter cube or 15.5 millimeter in diameter. This is to illustrate what is part positive. On the first image, we can see that this is just about positive nodule, 2002 millimeter cube. And on the second image, we can see the nodule which is really positive. It's 2111 millimeter cube. Modified ILCAP for Croatia is based on volume. We did have problems because ILCAP was and is based on average diameter, but then we talked about it and discussed it, and we said, okay, we are in Europe, and European stance is to use volume, and that's the path we went down with. Why volume? It's easy to say, because if we see an average diameter on these 2 images and then volume on the other on the other set of images, then we can see that the average diameter on the first image is 5 millimeter, and on the second one on follow-up is 7 millimeter for this small nodule. The difference is basically 2 millimeters. And if we go to check with volumes, it's 165 millimeter cube on follow-up and only 25 millimeter cube on the baseline, which makes a difference of 140. Basically, 140 is much larger number than 2. So it means that volume is much more sensitive for small changes in size of the nodule. Then another thing which is important with volume, that it gives a measure of potential, of malignant potential of the lesion, which is called volume doubling time. And we probably already know that which is less than when there is a lesion with less than 400 days of volume doubling times, it's probably malignant. Then we settled, we took a stance of an indeterminate lesions which do show volume doubling time between 400 and 600 days. And for those lesions which show volume doubling time of more than 600 days, we would really consider as benign. And all of that is about follow-up and how short or long that interval is going to be. We are going to have a lot of additional findings, which are also going to be the part of the structure report. It's something that is really important, so it makes more than just detecting a cancer. Quality control is extremely important part of the whole process. We do have quality control committee, which is international, which consists of specialists in physics, from in radiology and pulmonology, in thoracic surgery. Also, we have physicists there. So all those who could really add a value in follow-up and control of the program, so that we can improve the things which wouldn't be really good. As I already said, structural reporting is going to bring quality, and then we can really easily follow up the differences in between radiologists. Education, we have already done a couple of courses, and we are looking into further courses in future. We are also going to accept diploma from ST course as well, of course. And there are going to be regular reports, which is one really important thing. So those regular reports are going to be for pulmonologists, but also for GPs to see. We will be able to see on the level of counties where do we have more patients referred from, and where are the regions where there are less patients participants are coming from. So from that point of view, we could invest some effort or advertise more, talk to GPs to search for potential candidates with more enthusiasm, let's say. From the radiology point of view, for us, the dose is really important. It's paramount in this program, and we are going to have regular reports on an average dose for an average patient for a site every 3 months. And from that report, we are going to be able to see if some CT units should be worked with or improve the protocol and reduce the amount of irradiation. We are also going to see the report on radiologist categories, so that we can see if someone is really, who is in average and who isn't, so that we can improve again with education, of course. We have already done printed materials for each screening participant. It's info booklet, it's informed consent, and it's smoking cessation program, which is going to be offered to all the participants and to all those who are not going to be eligible for the program but are smokers, of course. And it's for free. Info booklet, it's 7 pages of text, which is written in an understandable way, easy to read for everyone to understand, with all the information that one could need to decide whether they want or they don't want to participate in the program. After that, there is an informed consent which participant has to sign on the radiology site, and then we can go for CT scanning. Smoking cessation program, there is a small pamphlet, leaflet, which looks like this. And it isn't in color on this one because it is printed, and that's the way in which the participants are going to get it. So what can we say? Is it really a national lung cancer screening program, or is it more? It is more, of course. It's a lung health check program, because we are going to look for so many other things. It's not only lung, it's even more than that, because we are going to note all the changes on all the organs that we see. When do we start? 1st of October 2020. So it's close, it's in 2 weeks, and the date is set. So we are already opening the slots for the first patients. Thank you.
Many thanks, Ante, for your presentation describing how Croatia has introduced the national screening program. As we know, many other countries are ahead of you in terms of having a national screening program, so it's really good that Croatia has recognized the importance of this for its citizens. Well done. So now we're going to move into the questions, and if anybody's got any questions for Ante, please start putting those in the Q&A box. But we're going to start with a question that I would like to ask Ingo. Could data and AI be a solution to understand the human service system and the customer needs in a holistic way?
Oh, I would sure hope so. Yes, please. But again, in terms of the data that we have, I think that's the main limiting factor at the moment. We don't have a lot of data on people's preferences, for example. So that's, I think that needs to be addressed first, and then I definitely think we can apply those methods to those data.
And of course, we mustn't forget that we have a richness in our health data, but we are social care and support service data poor. So there's that side if we're going to be truly holistic, isn't there? Maybe Ran, there's in the work that you've been doing in Claret, how is that, those sides of the holistic approach to people being addressed or not?
So again, Claret fortunately has had the tradition of working in multidisciplinary groups, with care being provided not only by solo physicians, but rather by a group that is including physician, nurse, as well as a lot of ancillary services by social worker and other community-based resources. And so I think this kind of combination is what allows a more holistic approach to the entire patient's needs. And as we are now putting into practice more and more patient-reported outcome measures, which are, basically something that is very much dependent on the holistic approach, because you cannot improve PROMs only by fixing something that is very, technical and medical. I think that will also help to guide us in terms of the compass towards a more holistic, people-centered approach.
Mm. Very good, thank you, Ran. We're now going to move on to, it's a bit of an evaluation question from Niamh Lennox-Chugani, where she's questioning whether there are any particular challenges in real-world evaluation of AI tools that may be different challenges to what we experience with evaluating digital tools generally. So, is there something special that we need to be considering?
I think it really much depends on the type of intervention we're talking about and the way it is practiced. So if you're talking about a tool that is being employed on a population level on the masses and is providing some kind of a tiered approach care to patients, I think it's pretty straightforward. You've introduced an intervention on a population level with an intention to treat, and now you need to decide in advance what your outcomes are, measure them continuously, and then see the outcomes in the usual methodology. I think that's more straightforward. Sometimes when you use AI, etc., for personalized care, for something which is very, very different from person to person, on a personalized manner, then the evaluation becomes a little more tricky, and the ability to be able to to account for all of the differences between different patients and to assess the impact of your intervention is very difficult. Finally, there's always the question about doing things in a randomized controlled approach and how costly and difficult this is on large masses of people in order to evaluate some of the impact of these measures. So I think this is not especially unique. I think it's relevant to the discussion we've had basically in IFIC for many decades now on the question of how do you evaluate interventions on masses for integrated care.
Mm-hmm. And maybe if I can add to that, I'd maybe say if we're looking at interventions targeting populations, we might also look into the methodology a bit more. So I know we've been doing an evaluation of the Gesundes Kinzigtal integrated care scheme in Germany just now, and we had a very extensive control design to look at data from different comparator regions across Germany. So I think also here, or when I'm looking at the idea of real-world trials that the pharmacological industry is pushing very much, I think we need to develop our methods more, but that's not specific to artificial intelligence, but that's specific to population-level interventions and determining their effect. I just want to go back to one point that Neve made in her question, and that's about quality, because here I just want to support what she said, that yes, ensuring quality in complex data sets is a more difficult task than in easier data sets. So what you wrote, Neve, about data cleaning taking a lot of time, I think that's certainly true, but on the other hand, I also think this is only footwork. So you just have to do it. It takes a lot of time, it's resource intensive, but it's not a principal challenge, is how I would see it.
And Ante, as a user, what have you got any thoughts on this evaluation side?
Well, it's beyond my expertise, isn't it? I'm a radiologist, and we basically use AI, and we are happy and welcoming new things and new programs which can support us and help us in our everyday work. And that's the way we look to AI, basically forgetting the data and the holistic approach. That's honestly what I can say, but yes, maybe some control loops should be installed everywhere, and if you always control from one point of view, one data set to another, that could maybe improve things and ensure quality. And because the basis of the quality is in constant asking and looking into data and into results, and that's the way to basically improve and control the quality of the program altogether, AI.
Thank you, Ante. And sort of taking that quality concept to the next level, what role do you think that regulators are playing or may need to play in the applications of AI tools? And associated with that, how can we as a community be more honest about the real world limitations of AI that you've alluded to, Ingo, and also the abuses of personal data? Ingo, would you like to start?
I can give it a try. I think that regulators should have a big role. I think coming back to transparency and quality of algorithms, I think we will not get that without regulation, to be honest. I mean, that's my view, and I'm sure there are different views about that out there, but I think that algorithms need to be open so that everyone can look at them and see how they're working. And I don't think that will happen if there isn't a kind of regulatory framework that mandates those algorithms to be open. And then we've had a lot of bad experience, not just in artificial intelligence. I'm thinking of these CNOS milieus that we're using in sociology, where it's never quite clear how those come about, and they remain a kind of black box. So I think that's an important thing, an important role that regulators have to play, but this is very much underdeveloped at the moment. In terms of talking honestly, I think we need to talk about it outside grant applications. That's the first step. And I think we need to be really upfront and keep that conversation going, that artificial intelligence will be good for some things, but not good for others. And we also need to be talking about those ethical issues around them, access and equality and so on, and just keep the discussion going, because that's how I see currently in Germany. We're talking about research data centers, and the only way to move those ideas forward is by discussing them again and again. Even if it's starting to get on your nerves, you just keep on having the discussion around it.
Any comment, Ran? Or
I think that was perfect.
Yeah.
I would like to say that regulators are really slow. and they are always coming a bit late. And then when they introduce their role, then it becomes maybe even too regulated or too complicated. On the other hand, we have AI that is developing basically partially on small things. It's not a holistic thing that you can regulate. It enters, it sneaks into every part of the life, of professional life, of population analysis, data, government, everything. So it's difficult to regulate that on a wider basis. I think that when it is already particular, maybe we should look into it as small things and then somehow regulate. When you enter something into the law, like we use some kind of AI or some kind of IT solutions into national screening program, then that kind of plan is already accepted as a part of regulation. So it became a part of regulation, even though not really thinking about it. So it just sneaks in. Maybe that's the problem that we should be looking into and address.
Okay. Thank you, Ante. There is one question that is related to the national screening program, and it's related to the fact, as we have stated before, that the social determinants of health are very important in providing healthcare, including these programs. So which initiatives have you undertaken to make sure that actually the ones with the highest healthcare needs are being reached with this national preventive program of screening for lung cancer?
Thank you for the question. We looked into problems that previous trials showed to have. Like Nelson, they addressed the problem of reaching the people of lower socioeconomic status. And they also addressed the problem of response rate. So when we looked into it and thought about it, then somehow we realized that maybe GP is the address, the point which should integrate the whole picture in the whole system. And the GP is the person who really knows his population. As you know, in Croatia, GP has a certain dedicated part of population that he treats. So he basically, that person knows, the GP knows the best his patient, and he knows their needs, and he knows how to approach each of them. It's a kind of personal approach. And I think that personal approach is what is going to make this primary response rate. Then we divided this response rate into primary and secondary. So primary is basically how many people are we going to get from the target population to be enrolled in the program altogether. And the role of GP and their relationship with their patients is what we count on to bring more people into the program, and particularly those who are of level socioeconomic status, which show to be a problem. And then on the other hand, the second response rate should be better, so that the proportion of people who are really going to show up for CT screening when they are once enrolled, because they are doing they are choosing their slot together with the GP at that side, and somehow I think that relationship is going to give them a kind of obligation to show up for CT.
Okay, so you're involving GP network and the covering of the population to ensure that actually using the trusting relationship between the GP and the patient to get the good response rate. Yes. Yes, and the GPs will also be able to refer to the community nurses to reach the ones who are, let's say, not attending so regularly to the practices.
There's the network that we count on, which is already developed in health centers throughout Croatia. And I think somehow that we think that it's the best possible approach, because just by trying to send some kind of leaflets or calls to anyone is not that effective. I think this is going to prove to be much better way to reach all potential participants in the program.
Thank you very much, Ante. I'm now just going to go to Ran because a couple of people have asked for some additional information about the CC map, both in terms of the author of the paper, but also on how it works and how it was evaluated.
Sure thing. So let me try to get access to the slide set in order to show it again. And here it is. So as you can probably see on the screen right now, the full name is the Comprehensive Care for Multimorbid Adults Program, or CCMAP. You can see the results that I've shown you before, and you can see some of the other authors, including Dr. Marcelo Lau, Kalanit K, and a set of other people at the CLEAT and the CLEAT Research Institute. Now, to tell you a little bit more about the program itself, for some reason it cannot show that. Let me see how that works. Again, let's see, this is technically challenging yet feasible. Okay, here goes. Okay, so what we see right now is some of the concepts that we're talking about here. So the way that this works is, first of all, there is a identification of the patients for this program, and the identification process happens through a predictive model that assesses the patients at highest risk of deterioration due to multimorbidity associated admission and deterioration risks. And that top of the pyramid is then we reduce from these the patients that, based on clinical criteria, are not amenable for massive improvement because of various specific types of conditions that render them inappropriate for this plan. And then we choose those clinics that have the highest concentration of these patients and that they have the highest burden of treating them, and they need the augmentation. On those clinics and on those patients, we add a nurse that has been trained on the CCMAP approach, and the nurse works in conjunction with the family physician of that patient. The CCMAP nurse works with the family physician to create an action plan that is comprehensive and takes into account all of the patient's needs and the potential integration of all the services that are available for him according to his needs. Now, the thing here is not to give the regimen of treatment for every disease separately, for diabetes, for hypertension, for the cardiac disease, for the neurological diseases, but rather to see the patient as a whole and provide him with an action plan that he can actually live through, and that would be most effective in their specific setting. And that kind of tailoring is the magic that this nurse does, again, with a continuous work with the physician. And apparently this has been exceedingly effective, and we have seen a serious drop in the admissions and readmissions, and this plan is now being introduced to the entire CLEAT system in massive scales, and more nurses are being trained by Efrat and and her team, and a lot of other good people working on this in parallel. So I think I'll stop here.
Can you stop sharing your screen?
Yeah.
Great. Thank you. I think that Zlata is going to ask another question to Ante in the first instance.
Okay. So how could ethical aspects in relation to surveillance be ensured if artificial intelligence is used in cancer screening programs? So the ethical aspects in relation to surveillance.
Well, I think the concern is about irradiation dose or something else. We are going to use artificial intelligence in volumetric analysis and comparison, and we are going to get volume doubling times and then decide of nature of the lesion. That's what we use artificial intelligence for. And then about about concerns, ethical concerns, it should be basically based, it should be looking towards radiation dose. I think that what we do, we are really controlling everything. So every 3 months we are going to get regular reports on irradiation dose per each site, per patient, and always try to load that further down, and keep an eye all the time on that thing. So that's one concern. The other concern, I don't know, would be maybe when we talk about ethics to data protection or something like that. We have a system of sharing data which is on ground for some 10 years already, which is called telemedicine, and this is what we are going to use to communicate images and the report and images, and that's one system. And on the other hand, we have developed a new system which is part of our central IT platform in Croatia, in which we share all the data, like referring the patient to CT, sending the report, and then referring the patient to pulmonologist, and then again the report. So it's a closed system which can communicate with other parts of the national system, but that's beyond this small part of the system, how to protect the data. I'm not sure if I answered well, because the question is not quite straightforward. But
I think yes. In my opinion, that was the main focus of the question. So thank you.
Yes, thanks, Ante. And we are almost at the end of this session. There's quite a lively discussion going on in the discussion forum area of the platform. So we're not going to discuss it, but I'm just going to hand over to Zlata to say a few closing words on behalf of the group here today in this plenary session.
Thank you, Leo. So what was an interesting comment from one of the questions that were raised is that by Aidan Carroll, if we accept that health and care is a complex system, then we accept that the future cannot be predicted. So, and during our discussion, we may say that we as the co-chairs and the speakers of today will not give up so easily on that. And so that is a closing thought. It is complex and it's not easy to predict, but still we're not giving up.
Thank you very much, and virtual round of applause to all our presenters. Thank you so much, and particular thanks to Ingo. Back to you, Fiona.
Thank you.
Thank you, Leo and Zlata. What a fantastic session that was. Great to see so much innovation happening in Croatia. Big thank you to Ingo Meyer for filling in so last minute for Jens Jacob Guzman, but you will actually be able to catch up with a recording of his presentation later. And absolutely great presentation once again from Ran Ballister. Ran is a former board member of IFIC and a great friend of ours. And the last time we heard him speak was in 2015 in Edinburgh. So welcome back and thank you, Ran. Also, just to say a big thank you to all our chairpersons. We really couldn't do the conference without you, and just what a great network we have from around the world. Please do continue the great engagement that you did already this morning. Ask your questions, put your comments, put links to other resources in the comments box, and have a great rest of day. We will be now moving on the half hour into our breakout sessions. So best of luck to everyone, to all our presenters, and have a fantastic day.